Okay. My name is Ray Delicata. I'd like to welcome you to another in the RSA webinar series, which is organised by the Royal College of Surgeons of Edinburgh. Today's webinar deals with a very common surgical emergency, acute appendicitis, which can still have the potential to give rise to problems not only in its diagnosis but also in its management. The webinar today is presented by Mr. Mark Bignell, consultant emergency and colorectal surgeon at Oxford University Hospitals. Mark trained as an undergraduate in London at Barts and the Royal London, and then went on to do his surgical training in the Wessex Deanery, where he also had a fellowship in inflammatory bowel disease in Oxford, where he now works. He's widely published and has a very keen interest in teaching at undergraduate and postgraduate levels. He sits on the Surgical Teaching Committee at the Medical School of Oxford University. I would also like to remind you that there is another webinar in this series on Thursday, which is about vomiting due to gastric outlet obstruction, and we shall, I'm sure, remind you again at the end of this webinar. As the format will be the same as with previous webinars, Mr. Bignell will do a 20-minute talk about acute appendicitis, and then there will be a question and answer session for about 10 minutes. I think that we can probably start off, and I would like to invite Mark to start his presentation.
Thank you, Ray, for that introduction, and welcome to everyone who's joined us today. As mentioned already, this is on acute appendicitis, and this is an extremely common surgical presentation. And in this session, we'll look at how appendicitis tends to present and the anatomical basis for this, before moving on to management, and then finally a discussion on the emerging role of antibiotics as a treatment, as this has gained popularity over recent months. So this is a clinical scenario that if any of you have spent time on an acute surgical unit will be familiar with. A 21-year-old male with a short history of periumbilical pain, now localized in the right iliac fossa, with local peritonism on examination. Investigations confirm an inflammatory process, and from this information it is possible to make a clinical diagnosis of appendicitis, and the treatment for this is appendicectomy. And I think this is probably the key learning point, if you don't take anything else away from this lecture, is that appendicitis is still a clinical diagnosis in this day of CT and MRI, and the treatment currently is still appendicectomy. Having an understanding of the anatomy allows us to understand the classic presentation that we've just described, and it also allows us to remove the appendix safely should they require an appendicectomy. For those of you who don't remember, the appendix is situated on the cecum at the convergence of the tinea coli. It has its own mesentery, the mesoappendix, and running through this is the appendicular artery, which is a branch of the ileocolic artery. This is important because the ileocolic artery, a branch of the superior mesenteric artery, means that the appendix is a midgut structure, the midgut running from the second part of the duodenum to the mid part of the transverse colon. This is important, this differentiation between foregut, midgut, and hindgut, because foregut structures tend to present with upper abdominal pain initially. Midgut structures such as the appendix present with periumbilical pain, and then hindgut structures present with lower abdominal pain. And this is because the visceral peritoneum, the peritoneum covering the organ, becomes inflamed and they get visceral peritonitis. As this peritonitis progresses, the pain the patient feels actually locates now towards the right iliac fossa. And this is over a point called McBurney's point. This is a point 1/3 of the way from the anterior superior iliac spine on a line from that point to the umbilicus. The pain moves to this point because the peritoneum supplying the abdominal wall becomes inflamed, and they therefore develop parietal peritonitis. And this is indicative of appendicitis. The onset of symptoms of appendicitis vary. The classic sequence symptoms occurs in about 50% of people. Most people, however, will have abdominal pain of some description, and they will complain of anorexia. The onset of their symptoms is usually within the last 24 to 36 hours. And so this varied presentation means that we sometimes need to use imaging to confirm our diagnosis. However, it is my experience that appendicitis for the most part remains a clinical diagnosis, and the majority of imaging is to exclude other pathology rather than to confirm the diagnosis of appendicitis. Ultrasound of the abdomen is not widely used in the UK, but in experienced hands it is a useful tool in the diagnosis of appendicitis. It's cheap and it doesn't have any obvious radiation effects, so it's safe as well. Transvaginal ultrasound scan is used in female patients when we're suspecting pelvic pathology. It's a very good way of looking at the pelvic organs, especially the ovaries. And obviously any ovarian pathology is high up on the differential list for right iliac fossa pain in a female. Finally, we have the role of CT scanning, and this over the last few years has taken on a greater role with CT scanning becoming more widely available. We tend to use it in appendicitis in patients who are over 45 years of age, and this is because over that age the incidence of other pathology such as diverticulitis or cancer increases. We tend to use it if there's a mass because obviously we wish to rule out other pathology. And if we think there's another diagnosis or the diagnosis is in doubt, a CT scan is a very good way of getting a diagnosis quickly. When we're considering appendicitis and patients with right iliac fossa pain, it's very useful to consider the differentials because these can present some pitfalls in clinical presentation. The first one to really mention is right-sided diverticulitis, and associated with that left-sided diverticulitis in a floppy sigmoid colon lying in the right iliac fossa. And this is probably the key reason for getting a CT scan in somebody over the age of 45, because over this age, the incidence of diverticulitis increases significantly whilst the incidence of appendicitis drops. The importance is that diverticulitis on the whole is managed with antibiotics alone, whereas appendicitis is still managed with surgery. I don't think I need to tell you that any female with abdominal pain needs a pregnancy test, and we're really looking to exclude an ectopic pregnancy, which if missed can have life-changing consequences for the patient. Appendicitis is also a great mimicker of other conditions. It's not uncommon for appendicitis to be misdiagnosed as a urinary tract infection when the appendix is sitting behind the bladder, causing bladder irritation. And if it's lying over the ureter, it can inflame the ureter itself and give a positive dipstick with blood present and then getting misdiagnosed as renal colic. The clue in the history is always that it's periumbilical pain to start with, or usually is. And there is an absence of symptoms associated with the urine, and obviously a negative urine culture when it's tested. If the appendix is lying in the right paracolic gutter, it can mimic cholecystitis. Cholecystitis, however, you will recall, is a foregut structure, and so tends to present with upper abdominal pain as opposed to periumbilical pain. And pyelonephritis, again, will tend to present with pain at the back to start with. But again, if the appendix is inflamed and sitting in that gutter, it can mimic both of these conditions. And finally, I think it's important to beware the diagnosis of a grumbling appendix, that a patient may say, oh, I've had this a few times before, or they may say that I've been diagnosed with irritable bowel syndrome, but on questioning, they've never really been investigated. And I caution you that irritable bowel syndrome is a diagnosis of exclusion once patients have been fully worked up on the most part. The reason these are important is this could be that the patient actually has underlying Crohn's disease. The population who have appendicitis is very similar to that population who first presents with Crohn's disease. And obviously the management may be completely different and certainly warrants investigation if you're concerned that the patient may have Crohn's. But assuming that we're happy with the diagnosis, we need to think about our initial management. Obviously, routine bloods are important, both to confirm the diagnosis, but also if we're thinking about taking the patient to theatre. And it's important to get a group and safe sample sent. The risk of blood loss from an appendicectomy is very low, but it is not uncommon to put a trocar into an aorta. It's a well-recognised complication, and therefore blood should be available. The patient should be prepped for theatre, and this means IV fluids. Patient needs to be booked, and dependent on the timing of theatre, they may be allowed clear fluids for a short period before they're made nil by mouth. Patients don't come to hospital with appendicitis, they come to hospital with abdominal pain, so don't forget their analgesia. This can usually be given safely orally, but you must consider IV or IM routes if for whatever reason the oral route is contraindicated. And then finally, we talk about antibiotics. Obviously, you will have been taught the sepsis 6 guidelines and that antibiotics should be given early if sepsis is suspected. And this is true if a diagnosis of appendicitis has been confirmed and that we're waiting surgery. If, however, the patient is somebody who the diagnosis is unclear and they require admission into hospital for observation, then antibiotics shouldn't be given. The reason is that the natural history for appendicitis is that it will worsen over time, whereas other conditions such as viral illnesses should improve, and therefore admitting a patient and seeing how they progress over 12, 24 hours is a very valuable surgical tool. When you give antibiotics to the patient, you eliminate this tool because the patients will get some benefit from 1 or 2 doses of antibiotic. And when they're seen the next morning on the ward round, it's very difficult then to know have they just got better because their disease, whatever's causing them to be unwell, is getting better, or is it because they've got appendicitis and the antibiotics have made them better? So in general, if you bring somebody in and you put them on antibiotics, what you're saying is they need an operation. So if the appendicitis is suspected, it's been proven on a CT, or you've got good clinical grounds, then they should be started on antibiotics whilst awaiting theatre. But if a patient is being observed, then antibiotics should not be given unless definitive imaging has been taken and suggests that something else is going on. So I think now's a good time to just sort of go over a bit of terminology. Appendicitis is inflamed appendix, which may or may not be gangrenous, it may or may not be perforated. And this sort of brings us on to complicated and uncomplicated, which we'll deal with on the next slide. But we'll also talk about terms such as an appendix mass, which is where the appendix is inflamed, but the tissue surrounding it adheres to the appendix to form a mass, which is palpable on examination, or it can form an appendix abscess, where the appendix tends to perforate, but the perforation is contained. And this forms an abscess which present not only with pain, but often malaise and a swinging pyrexia. These terms are slightly outdated and have been superseded now by just simple and complicated appendicitis. And this is mainly because of a lot of the research that's been done recently into antibiotics, which have now used these terms as a way of differentiating who antibiotics should or shouldn't be used in. And simple appendicitis is anybody who has a simple inflamed appendix in the absence of gangrene, perforation, or an abscess. Whereas complicated appendicitis is anything that's not that. So a perforated appendix, a gangrenous appendix, or the presence of an abscess. And often it can be associated with a mass. It doesn't tell us who would and wouldn't benefit from surgery, and it doesn't tell us who would and wouldn't benefit from antibiotics, but it's simply a way of trying to classify appendicitis into 2 groups for research purposes and also for audit purposes if you want to see how your sort of appendix rate and complication rate stacks up compared to national figures. In the UK, surgery is still the mainstay of surgery. It certainly is the mainstay of surgery for uncomplicated appendicitis, where the laparoscopic approach is undertaken. This allows thorough assessment of the abdominal viscera, so including the pelvic organs, which is extremely useful in women, and it's an extremely safe procedure. Antibiotics we tend to reserve for complicated appendicitis, those patients with a mass who are clinically well. There is, however, growing evidence for antibiotic usage in uncomplicated appendicitis, and we will discuss that later. So I don't know how many of you have ever seen a laparoscopic appendicectomy. So I've got some slides here just take you through the steps. This is the initial view once you have safely entered the abdomen. The surgeon will first off try to identify the appendix, but also look to see if there's any other pathology that could explain the patient's symptoms. And in this view, you can see an inflamed, slightly thickened appendix with its mesoappendix underneath it. And if you track that down towards the cecum on the right, you'll see that there's a Taenia coli. And if you were to move that cecum around, there will be 2 more Taenia coli which converge, and that's the base of the appendix. And then just below that is the terminal ileum. And that's the view that we're looking for when we start an appendicectomy. There are a number of ways of removing the appendix from its mesentery, but the most common, certainly in the laparoscopic era, is to skeletalize the appendix by taking the mesoappendix off of it. On the picture on the left, you can see where this has been started. So the grasp is holding the appendix up with the cecum at the bottom right, and the mesoappendix is being taken off with electrocautery. When you look at the picture on the right, this process has been complete. The mesoappendix is now sitting free from the appendix itself, and this dissection has been undertaken all the way to the appendix base. And any further dissection at this point would injure the cecum itself, and so this is therefore where we stop. At this point, we then place endoloops, which are loops of tie that go around the appendix, and we tend to place 2 at the base and 1 just above it. And in the second picture, you'll see us dividing the appendix. And in the third picture, you see the appendix itself has been removed, and what's left were the 2 ties on an appendix stump. As you can see, the stump is quite short. There is a condition that people talk about, stumpitis, and this tends to occur if this stump is left long. But in general, if this is left to sort of 0.5 centimetre or 1 centimetre in length, the risk of stumpitis is almost negligible. Once the appendix has been removed, it's placed into a retrieval bag, you see here, and then this retrieval bag is removed via the main laparoscopic port at the umbilicus before the surgeon closes the rest of the abdominal wounds. So let's talk about the role of antibiotics in appendicitis. This is a controversial issue because of the simple nature of appendicectomy, the minimal complications associated with it, and therefore antibiotics traditionally have been used for complicated appendicitis in those patients who we feel are not fit for surgery. However, there is growing evidence that antibiotics can be successfully used in uncomplicated appendicitis and remove the need for surgery altogether. Antibiotic treatment has been shown to have lower pain scores and a quicker return to work compared with surgery. And in patients who have antibiotic treatment in their first index admission, 90% of them will avoid surgery at that time. 30%, however, will require surgery in the first year, and this rises to 40% at 5 years. So odds are that if you have antibiotic treatment, your inpatient stay will be shorter and quicker, you'll return to work quicker, and the chance of you needing an appendicectomy in the next 5 years is 4 in 10. That seems pretty reasonable. So why has the uptake of antibiotic use been so poor? Why have surgeons been so resistant? Well, the first thing is, most of the trials have compared antibiotics versus open surgery. Open surgery, certainly in the UK, is pretty obsolete except for the worst appendicitis cases. And it's generally felt that if you were to run these trials comparing it with laparoscopic surgery, there probably wouldn't be as much difference. It's certainly fair to say with laparoscopic surgery, you can get a patient home the next day, and they should be able to return to work within a week to 2 weeks. There's no clinical or radiological way to predict uncomplicated appendicitis, which is what most of these trials have looked at. And therefore, it's not clear until you put a laparoscope in who is going to benefit and who isn't from antibiotic treatment. Once you have the laparoscope and the instruments into the abdomen, it's only a simple procedure to remove the rest of the appendix. It would make sense to use antibiotics in patients who are greater risk, such as the elderly and the immunocompromised. But these patients have been excluded from the majority of the trials, and we don't actually know whether it's beneficial in these groups. So again, we tend to perform an appendicectomy in these patients. And then finally, unexpected lesions can be missed with a non-operative approach. Now, neoplasm of the appendix is rare. I don't want you leaving this lecture thinking appendiceal cancer is very common. It's very rare. However, its incidence does increase with age. A third of appendiceal malignancy will present a third of the appendiceal malignancy that was found in over 65 initially presented as inflammatory appendicitis. And this whole group will be missed if we adopt an antibiotic approach. And it's this group, the over 65s, where the argument is that it's probably better to use antibiotics, and therefore you have a conflicting argument. But I think the biggest reason why laparoscopic appendicectomy still reigns superior over antibiotics is that it's safe and it's effective. We know it works, we know the patients go home, and we know they don't come back with appendicitis later on. And at the moment, the evidence still isn't compelling enough for most of the surgical community to be persuaded. However, the COVID-19 and the current pandemic is probably going to change that. We had to undertake new ways of working with the pandemic, and it's forced change upon us. There are a number of studies underway at the moment looking at how we've managed appendicitis during this pandemic, and they may well give us a better idea of who we can operate on and who we should selectively not operate on. And therefore, the future in the next 5 years may change drastically. I'd like to leave it there. I think appendicitis is a simple topic that tends not to cause much confusion, but it is important to know about because it is an extremely common condition. And in my book, it's still a clinical diagnosis, with the role of CT being there to exclude pathology in patients over the age of 40 or 45. Laparoscopic surgery, in my opinion, remains the treatment of choice in non-complicated appendicitis. And complicated appendicitis, if associated with a mass or an abscess, should be treated non-operatively with an interval appendicectomy when the patient gets better. I shall leave it there, and I'm ready and willing to take questions. Thank you.
Right. Mark, there have been some questions which I shall communicate to you. Probably one of the commonest questions that we've had about your talk and appendicitis in general has been the role of the appendix in the gut microbiota, and there've been one or two questions again with regards to the role of appendicitis and appendicectomy in the development of inflammatory bowel disease. What are your views with regards to that?
With regards to the microbiota, yes, it's felt to be a harbour that helps supply the large bowel and its microbiota, and therefore removing the appendix theoretically can cause problems with the gut microbiota. However, I think the gut microbiota is far more complex than we think. And ultimately, if you need to have your appendix removed because it's perforated, it's making you unwell, then I think you don't have any choice. It's a bit like removing somebody's gallbladder. We all know the gallbladder serves a function, and you can live life without your gallbladder. We have taken out hundreds of thousands of appendixes over the last however many years. And I think if taking the appendix out had a significant impact upon patients' well-being and their microbiota, we probably would know by now. Certainly you don't see patients attending with functional abdominal pain, diarrhea, following their appendicectomy. So I think it's a safe thing to do. The role of the appendix as a treatment for UC is an interesting one. I think it's reasonable in somebody who's very resistant to have their colon removed, to have their appendix out to see if it makes their symptoms better. I think the evidence is not strong in either way, and I think it is something that can be explored with patients if they fail medical treatment. But I think you have to strongly counsel your patient that having an appendicectomy may not work, and they may still need a colectomy.
What about its role in the development, as it were, of Crohn's disease? Because there is some evidence, I think, to suggest that patients with post-appendicectomy are more prone to developing Crohn's. What are your views with regards to that?
I've seen those papers. I tend to sort of sit on the fence. I think there's so many confounding issues with this, and there's nothing to say that what you're seeing with the appendicitis isn't the first presentation of Crohn's. And then they are developing sort of more obvious terminal ileal Crohn's at a later date. I think Crohn's is very poorly understood for its etiology. Whilst we understand a lot about it, I feel we don't understand enough. And still, it still harks back that if you need your appendix out, having an appendicectomy is a safe operation. I'm not a big fan of the antibiotic treatment. I'm not sure how it works in clinical practice. I think you find you put patients in for 2, 3, 4 days on IV antibiotics when you could have got them home quicker with a laparoscopic approach. I have seen significant numbers of patients come back needing their appendix out. And certainly in the COVID era, we found that using antibiotics doesn't seem to work as well as the papers would suggest. And I think whilst there is the role of the appendix isn't fully explained in a number of diseases, I still think appendicitis is a surgically managed condition.
Yeah, thank you for that. And there's been a question, Mark, with regards to acute appendicitis in pregnancy.
Yeah.
And the question really relates as to whether the Alvarado score in general is still useful in the management of appendicitis, and whether there are any other scores that are useful in appendicitis in pregnancy.
Right, that's an interesting question, and you'll probably noticed in my talk I haven't mentioned any of the scoring systems.
Indeed, yes.
And the reason, and I don't know about you, Ray, in your practice, but I've never used them. And when I was a junior, my seniors never used them. My juniors don't use them now. I think they're used for research purposes, but I don't know anybody that uses a scoring system in clinical practice. I think it's still very much a clinical diagnosis, or if there is doubt, usually a CT is done to confirm the diagnosis. In pregnancy, I think the risks of appendicitis to both the parent, to the mother and the baby, are so high that I think if there's any doubt, either an MRI scan or an ultrasound scan by an expert radiologist is actually the way to go. And I'm not sure I would trust a scoring system. That's an anecdotal thing. I can't tell you a paper that says that. I just don't have experience of using scoring systems.
I would agree with that. I've never used scoring systems. I think the time-honored approach of examining the patient several times within a few hours of each other, I think that works very well for me, and I've always used that. Obviously,
I would add to that in a young male, anybody under the age of 30 who's otherwise fit and well, who presents with right iliac fossa pain, I would say 99 times out of 100, if they're tender with a bit of peritonism in their right iliac fossa, that's their appendix. It's very rarely something else.
Yeah, there's a very interesting question here with regards to particularly a female patient that presents with pain, undergoes ultrasound, which is normal. She's got normal CT, normal white cell count, normal C-reactive protein. The pain persists, and we resort to a diagnostic laparoscopy. And at a diagnostic laparoscopy, the appendix is normal.
Yeah.
What do you do? Do you leave the appendix, or do you leave it?
I tell my patients that they're all going to have their appendix removed. And I do this for 2 reasons. First, they've presented with pain in the right iliac fossa. And I have taken out what look macroscopically normal, only to get histology back that say that there is mucosal inflammation. And accompanying that, the patient the next morning is better and goes home. So that's the first one. So I think even just by looking, I remember an old consultant of mine when I was a houseman said the only way to confirm appendicitis is to give it to a pathologist to look under a microscope. Yeah. And the second thing is, if you don't take the appendix out and they're no better in 2 days, you still don't know that it's not appendicitis. So you almost have to go and take the appendix out. But also, in young women who have recurrent right iliac fossa pain, actually removing the appendix at the time eliminates that confusion that they may subsequently have 6 months, a year, 2 years later when they represent again with right iliac fossa pain, because the appendix has gone and they know that they can't have appendicitis. And in my experience, the dangerous side from doing a laparoscopy is putting the ports in generally. And I think once you're in there, removing what looks like a normal appendix is safe and has got very, very, very little morbidity associated with it in experienced hands.
There's one last question. I think we've just about got a little bit of time for it. And it's to do with the management protocol if we encountered pus when opening the peritoneum in open appendicectomy. What would be your management protocol?
If you in an open appendix, well, first and foremost, if you're doing an open appendicectomy, I assume you're reasonably confident it's the appendix. And there must be a reasonable reason why you can't do a laparoscopy, because I think first and foremost, I would want to deliver the appendix. And if the appendix is inflamed, I would remove the appendix. And then what I tend to do, or what we always used to do, was we tended to put a swab on the stick down and towards the pelvis and up towards the right upper quadrant and just sort of mop the pus up. And then we used to leave them on antibiotics. Very rarely did we ever make a bigger incision for it. I mean, it's not a problem that we usually encounter these days, because I can't remember a time that I ever started an appendix open. Because they're always done laparoscopically. So, I mean, I think if you shouldn't find much pus with a perforated appendix. I think if you find a lot and you're concerned and the appendix looks relatively normal, you have no other option, I think, but to convert to a midline laparotomy. And that's the beauty of a laparoscopic appendix. You can put it in, and if you swing the camera around and it turns out it's a perforated duodenal ulcer, you can repair that laparoscopically. If it's the gallbladder, you can remove that if you need to. If it's a hydrosalpinx, you can remove that. I mean, that's the beauty of putting a laparoscope in. And that is why it beats antibiotic treatment, which is why it beats an open appendix. I think it's revolutionized the way we manage right iliac fossa pain in women, and the way we treat appendicitis.
Yeah, I would agree with that, I think, as well. I think, sadly, that's the end. We're going past the half-hour mark. I thank you very much, Mark, for a very, very, very good presentation, which I really enjoyed.
Thank you.
And I would like to remind everybody that next Thursday's presentation is posted up onto the screen, and it's to do with copious vomiting due to gastric outlet obstruction, immediate and definite management. And again, it's on Thursday, this Thursday at 4 o'clock. Thank you very much for attending this webinar. Thanks, Mark, once again.
Thank you. Thank you, everybody, for attending.